Hello everyone and welcome to today's ELFI webinar. My name is Bethan Edwards and I'm going to be introducing our great speakers for today. Good morning to everyone who's joining us from a variety of places around the world, which is really exciting. Today we are going to be listening to Virginia and Katie in conversation, who are going to be talking about how the language of pharmacy has changed. A couple of housekeeping points before we start. If you have any queries or questions throughout the session, please pop them into the chat and we'll do our best to help and answer them. The recording of today's session will be available on the ELFI website to ELFI members. And at the end of the session, we'll have time for questions for Virginia and Katie. So if you do have any questions, please use the Q&A function, which you should see on the bottom of your Zoom screen, and put any questions in there, and we'll have time at the end for those. All right, so I am going to hand over to Virginia and Katie, who are going to be talking to us about the language of pharmacy and the changes that Katie's experienced.
Right, thanks Bethan, and welcome to everyone. It's lovely to see some familiar faces. Well, see them in the chat box. As you can see, Katie and I are sitting nice and close together in the one room, and that's because we live on the Isle of Lewis, and in fact Katie lives around the corner from me, so we're neighbours. And some of you might be aware that my background is nursing and Katie's background is pharmacy. So let's start off by asking Katie, can you tell us a bit about your pharmacy background?
Yeah, hi, thanks for having me here today. I suppose the beginning is where I studied. I studied pharmacy at Sunderland University in the northeast of England, which is where I'm from. I don't know if you can tell my accent isn't Scottish. And I qualified with a Master of Pharmacy degree back in 2009. I've worked in a variety of different roles over my career. So I started off working for a large chain of pharmacies. I think I worked in about 9 different stores, working from small chemists to larger flagship stores, where I was a clinical services pharmacist at one point. Right. So I did things like travel health clinics, flu vaccinations, warfarin clinics, and then I eventually went into management roles. After that, I moved up to Scotland and I did a bit of locuming, so small independent pharmacies, which I still do a bit of now, to be honest. I like to keep my hand in community pharmacy, but I've since transitioned over to primary care pharmacy. So that's working within GP practices, so helping the multidisciplinary team there with the pharmacy side of things. Recently, I have just started a new role with Cambridge Press and Assessment, and I do a lot of work with the assessment side for English-speaking pharmacists. Okay, and that's pretty much it. So
that's as a subject matter expert.
Subject matter expert is what I do for Cambridge.
Well, that's quite a variety of experience in pharmacy. So tell me about the sort of language that you use in your main role.
Yeah, so my main role is the primary care pharmacy job. And it involves quite complex discussions daily about medication use. So it could be a case of I need to speak to a patient about stopping a medication they've been on or starting a new medication. Sometimes it's changing medicines. This can be due to a number of reasons. So things like guidelines might have changed. There might be recent changes to safety information about older medications. Maybe a patient's had a test result that's come back during monitoring and we need to change something there. Or sometimes it's just a change of formularies and it can be a cost issue. An example, really, I could speak to a patient and say, you know, your medication is going to be discontinued in a few months. We need to talk about changing you onto something else. So any conversation with medicines are quite complicated. All of these changes, they obviously require the patient to give what's called informed consent. So I have to make sure that I avoid using language that may sound like I'm persuading them or influencing them to make a decision. And I have to just use language that highlights the importance of something, and makes sure it's clear for them to understand. So an example would be something like, I know you're used to using cream X, but actually the cream that we're suggesting you change to has the same ingredients, but it'll cost the NHS less to supply. Sometimes, you know, pharmacists have a tendency to phone patients and open the conversation with, we're going to change you to this medication, is that all right? And instantly the patient will put their wall up and go, whoa, you know, I'm happy with the medication I'm on. It may have taken me months or years to get content with the actual treatment that I'm using, and you're just ringing me up and saying, you're going to change it? What? Right. Hold off, you know. So I make sure that when I'm speaking to a patient, I come in with a more empathetic you know, conversation to begin with. So I usually start with a conversation by saying, you know, hi, I'm the pharmacist. I'm just calling you today because I can see you've been using Cream X to treat your eczema for a number of years. Do you still find it helpful? Oh, you do? Oh, that's fantastic. Great news that it's still working for you. Now, I actually have to phone everybody at your practice today just to let you know that there's actually a brand new cream available on the market. It does the same thing. It has the same ingredients in it, but actually it's going to cost the NHS a lot less to supply this to you regularly. So how do you feel about maybe trying that medication today instead of your regular cream? And that, I feel, is a way in with the patient. Instead of just telling them, this is what we're going to do, they have the opportunity there to make that decision themselves. It's using patient-centered language. That's how I would always describe it. And I've made sure that I do this throughout my career, whether it's in community pharmacy, whether it's in primary care pharmacy, that always the patient's at the center of the conversation.
Okay, so do you find that the sort of things you talk about with patients and other healthcare professionals has changed since you first qualified?
Yeah, I would say so. I think patients are a lot more aware of their own health these days. You know, they might come in to me in a community pharmacy setting and say, I've got this symptom, or I think I've got this condition, or they've looked online and they've not just come to me and said, I've got a rash, can you have a look at it and please help? They'll now come in and say, I've got a rash, I've been on the internet, this is what I think I've got, this is what I think you need to treat me with. And it's quite difficult, you know, from 2009 when I qualified to these days, there's definitely been a change where the patient's coming in with a lot more knowledge, and it's not necessarily always the right knowledge. So what we have to do is we need to be aware that a lot of patients have different levels of health literacy with, you know, with regards to looking at information on the internet. And during my degree, what they advised was that we pitch any interactions to patients as if they're a 10-year-old. Now, I know that's a generalization. Obviously, a lot of people have a higher level of understanding than a 10-year-old. But in my job, it's vital that the patient understands the information that I'm giving to them. So it's always best to explain it in the most simplest of terms. I'm always very careful to avoid any medical terminology. So that I just want to make sure that I'm clear with what I'm saying. An example of that would maybe be if a patient was prescribed a medication and it says on the medication, this medication is for hypertension. I would never use the term hypertension with the patient. I'll always make sure I say this medication for your high blood pressure, so that they understand what they're actually being treated for. Some patients may know what hypertension is, great, but we always want to make sure people understand the information we're giving them. I tend to use, when I'm giving information, a lot of checking and clarification techniques. So personally, I like to use what we call the teach back method, which can be viewed online if you want to have a look into that. But it's a lot of, I've given you a lot of information all in one go. I feel like you've been bombarded with information. to put my mind at ease as a pharmacist,
Right.
can you just tell me what you think the main points are from
Right.
that conversation?
Mhm.
And that way I know that when you go away,
Yeah.
you've remembered the important bits of the conversation.
Mm.
And if when you repeat them back to me, you haven't, you've missed some of them,
Right.
I'll make sure to write them down so that you can take them away with you.
Mm. Mm.
I suppose another thing would be, it's really important not to commit 100% to a diagnosis these days, especially over the counter. Maybe back in 2009, a pharmacist would say, you know, oh, that might be eczema, that'll be ringworm, here's a cream for it. But what you need to do these days is you need to make sure that you're always leaving a window open for an opportunity that it could be something else. So we'll tend to use language like it's likely to be this, or it could be that. This is what we'll treat it as, and if it's no good, then we'll come back and we'll either send you to the GP or we can treat you for something else. But you can't absolutely say I am 100% sure that is what you've come in with. Yeah. And that's definitely something that's changed. So I suppose I'm kind of in, yeah, I'm kind of jumping in there and saying, this is what it could be. This is what I'm going to treat you with. If it's no good, maybe go and see the doctor because it might need further investigation. So I'm almost an intermediary between sort of the patient and the doctor there. Some conversations, I'm going on and on here, sorry, but
That's interesting.
some conversations I have are a result of, like I said, the patients listening to misinformation in the media. So I'm sure everybody's seen the headlines that are out there in the newspapers. Every now and again, there'll be a punchy headline about your medication. A common example, I suppose I would use, is the statin medication. We often get patients coming into the pharmacy that you know say, oh, hello, I'm on a statin and I read in a newspaper yesterday that it's going to kill me, so I'm not going to take it anymore. And that's the welcome to the conversation. So I have to be really cautious about the language I use when I talk to these patients. I don't want to say to the patient, you know, you read it in a newspaper, and I don't want them to feel stupid, you know. I want to empathize with them. They obviously have legitimate concerns. They're talking about stopping medication here that they've gotten from a doctor. So I need to make sure I understand their concerns. And yes, I'll say to them, all medication can have side effects, but you know, the reason they're on that medication, it's more important for them to take the medication. And that's why we do monitoring for the patients. So you know, before I talk to them, I'll check for the statins, for instance. Are you having any sort of muscle pain? So there's a red flag. If the patient says, no, I'm not having any of the muscle pain, they're probably not going to be in the small amount of people that have issues. I suppose the kind of language I would use would be, oh, I can see why you're concerned. Thanks for coming in and talking to me about this today. All medicines can have side effects, but not all of people are likely to suffer from those side effects. There is a very small amount of patients that suffer with serious side effects from that medication, but that's the reason why the doctors monitor you quite regularly. Do you remember when you first started the medication and the doctor called you in for a blood test and then they had a conversation with you about the medicine? Yes, well, that was them monitoring you to make sure that you're not going to be one of these patients that suffers with that. So the conversation you've had with me today, you're not having any of the side effects I'd be concerned about. And there is a reason why the doctor has you on that medication. So have you got any further questions about it today? And I like to make sure that the patient leaves that conversation feeling content that they're still happy to continue with the medication that they've been given. You know, it's a combination of empathizing with them about their concerns and explaining the careful monitoring process. I've got to make sure that I de-escalate the situation here. What I don't want is a patient telephoning the GP 5 or 6 times and wasting their time about this. Or worse still, the patient leaves the room and stops the medication altogether. It's always important to remember, though, that the patient and the prescriber agree on a course of treatment together these days. It's no longer, I'm the prescriber, I'm going to tell you to take this medication. It's now an agreement between the two, and the information for why the patient takes the medicine needs to be presented clearly in order for the patient to make an informed choice.
It's a real rapport, isn't it?
Definitely, yeah.
And what about lifestyle changes, what advice would you give? Or is this something that pharmacists talk about with patients, about making lifestyle changes?
Yeah, it actually is now. It's quite high on the Scottish Health agenda at the moment to discuss lifestyle changes. So lifestyle changes, I'm talking about things like smoking cessation or diet or exercise. They're obviously modifiable risk factors for a lot of diseases. So it's an important conversation to have with people. And I know it can be quite a difficult conversation sometimes.
Yeah.
I tend to ask during a consultation with a patient, I'll tend to start with a closed question to begin with. So I might say something along the lines of, do you smoke? Or do you manage to do exercise? And then after I've gone through the closed questions about each lifestyle issue, I'll then choose one to discuss in further detail. So I'll only choose the one, not because the rest aren't important, but because I don't want the patient to feel like they're being lectured. You know, I'm trying to build a rapport with this patient. The last thing I want to do is just go into, you know, you shouldn't be smoking, you should be exercising more, you should be changing your diet. You know, it's really important just to choose the one, build that relationship with them and try and encourage them to make even just a small change. At that point, once I know which one that I'm going to discuss, I can move on to more open questions just to try and find out a little bit more about that. So I suppose an example would be, you know, can you tell me more about why you started smoking again last year? And I might get a bigger picture of what happened at that point. And sometimes I suppose I'll use something called funneling questions to move from just the general information to specific details about that patient and that situation. I can go on to record the discussion I've had. We can talk about the outcomes. And then the next time that I deal with that patient or another prescriber deals with that patient, they may choose to either continue that conversation further or to choose a different lifestyle event to discuss.
But always just picking one so that they're not overwhelmed.
Yeah, but you're not going to like it if I go at you with 3, you know, change your diet, change your exercise habits.
Even though we know that we should. So, I mean, you did mention patients coming in having looked up information on the internet, but how has the internet changed your conversations with patients?
Yeah, like I said, it's definitely changed a lot. One of the things with the internet that's positive though is I try to signpost patients to information online now. There's a lot of support groups online which are quite commonplace. You know, if you get a long-term condition diagnosed, there's a lot of online support these days, but the patient needs to be aware that they're there. You know, they also need to be cautious about what information they read online. So I'll always encourage people to look at information online, but I want to make sure that they're very cautious about it. So language, I suppose I'll use would be things like, you know, it's great that you're trying to find out more information to help you make some health decisions here. But I'll always direct them to websites that are useful and accurate. So I might say, you might find this website, you know, useful, or this website might have some really good information that's really easy for you to understand. But I'll make sure, even though they're using the internet more, that it's really important to listen to professional advice from clinicians. The internet isn't going to replace that. I have to be quite firm about this because, like I said, many patients come in and think that, you know, what is it, Dr. Google? Is that what everybody calls it? And it's not always the case. You need a clinician there to actually do the full diagnosis and treatment. So I'll say it's really important that you listen to your doctor or your pharmacist or your nurse to get accurate information for your particular condition.
Well, we've been talking about verbal communication, but obviously there's a lot of written communication in pharmacy. I'm thinking about written prescriptions. What sort of pitfalls are there in this area?
Okay, so back in 2009, when I qualified, a patient would bring in what we call a paper prescription. So you've just been to your doctor, you bring in the paper prescription. It's got all the information on about what your prescription is, and the pharmacy transfer that details over onto a medication label for you to take away. How it used to work is, for example, a patient might have been prescribed prednisolone 5 milligrams, 8 tablets a day. The pharmacist would look at what the doctor's written, 8 tablets daily, pop that on the label and say, right, you know, the patient's not really going to understand 8 tablets daily. There's a chance that the patient might accidentally take 1 tablet 8 times a day. And with prednisolone, that's not going to work.
No.
So what I used to do is I used to just make sure I wrote very clear instructions that would say, take 8 tablets once a day.
Right.
And that way the patient, you know, understands exactly what they should be doing. Now with electronic prescriptions, which come with a barcode on them, we have a machine in the pharmacy, we scan them. The information is literally, it's transferred from the doctor's computer, exactly how the doctor's written it, across to the medication label automatically.
Right. Yeah.
So in that example, the prednisolone, the label automatically would just say, take 8 daily. We have to manually go into the system to override that as a pharmacist now.
So that's an extra check, really, isn't it?
Yeah. And also, you know, it's missing out the language used by pharmacies. In essence, we're giving out the medication with the language from the prescriber, as opposed to the language from the pharmacist at that point.
Sure. Yeah.
So I need to make sure that we're very careful in that respect. And another thing that comes through on prescriptions is we still see some of the Latin abbreviations.
Right.
They're no longer encouraged. So things like, you know, BD, instead of 2 times a day, it's much safer to use the clearer language, and it avoids any sort of error as well in the long run.
Sure.
But I suppose recently, I mean, I recently undertook the independent prescribing course to be an independent pharmacist prescriber. It means I can prescribe anything now within my level of competence, but you know, it does depend on the information you're given as to how happy you are prescribing. And when I look at the patient records, I've noticed it varies massively with how prescribers make medical records. So, you know, although there's a standardized abbreviation for things, you'll find that not everybody follows that.
Yeah.
So it's a bit of detective work to try and find out what's going on with the patient. I might see something like, you know, an upward arrow with BP or HYP or HBP, and they all might mean patient has hypertension. But, you know, there's no standard language. And you're then thinking, am I going to prescribe based on guesswork, or you know, do we need more information there? It definitely needs to be clear when it comes to prescribing to avoid any safety issues.
And finally, did you notice any changes in patient behaviour during the COVID pandemic? And if you did, how did you change your communication style?
So absolutely through COVID, you know, even from the very start of COVID to a couple of years in, we noticed a massive change during COVID. There was a massive increase in frustration levels. Patients were having to wait longer for prescriptions to come down from the surgeries.
Right.
They were waiting longer for the prescriptions to be made up. There was a massive increase in workload. So this is naturally going to happen. And there was supply issues, you know, you couldn't get the medication on time. So there was a lot of issues, and I can understand the frustration. But I even noticed that patients that I had a really good rapport with before suddenly became frustrated because they had really high stress levels. Everybody was stressed about COVID to begin with, never mind stressing about getting your tablets on time and things like that. But remember that most of the GPs weren't doing face-to-face conversations at that point. Yet you could walk into a pharmacy without an appointment and have a face-to-face consultation with a pharmacist. So I think we sort of became the go-to. Anything about your medication, we're going to come and we're going to, you know, be stressed around you in the pharmacy. And it made our jobs quite stressful as well. So I had to make sure that I adapted my communication skills, I suppose. I needed to be able to de-escalate and to calm people down. So, you know, there was a lot of empathy to show that I did care, and I needed to be aware of my body language as well. You know, like I said, we were stressed. I can't give off a stressful vibe when the patients are coming in stressed as well.
Yeah, so in fact, a complete change. Well, that's been really interesting. I think from my point of view, thinking about a pharmacist, you know, you can make the mistake of thinking that you just give out pills. But there's an awful lot of communication, and surprisingly, well, not surprisingly, but those communication skills are exactly the communication skills that we want our language learners to use. So yeah, it's been very, very interesting. So I think we're ready for some questions.
Super. That was really interesting. Thank you so much. Everybody who's in the session, please feel free to put in any questions you have for Virginia and Katie on the Q&A, and we've got a few minutes for Katie and Virginia to take those questions. I might start with a question. So it's been really interesting to hear about all of the communication skills you use, and as Virginia said, for us as teachers, it's really reassuring to hear that you're also using all of these kinds of communication skills that we're recommending to our students and recommending as best practice for exam preparation or any kind of communication. You talked about lots of different ways that you communicate. You talked about de-escalation, you talked about signposting, you talked about dealing with patients who've done a lot of research on the internet. What do you find the trickiest in terms of communication out of those different scenarios?
Oh, that's a good one.
Okay. Sorry if it's too difficult. It's just interesting.
I think sometimes it depends on the actual patient. You know, some patients might come in with information from the internet that's completely wrong, and they'll take the feedback on board straight away and thank me. Oh, thanks for putting me right, and oh, that's great, and I'll make sure to come in and ask for you again next time. But other patients might come in and say, no, you're wrong. I'm telling you, this is what I think I've got, and this is what I want you to sell me to treat it. And if I don't diagnose the same issue, I'm not going to sell you something that isn't going to treat. You know, it's quite hard to have those discussions. I suppose another difficult conversation is sometimes with the prescribers. So as a pharmacist, sometimes, you know, a prescriber might have, I don't know, given a slight overdose of a medication to someone. And I have to ring the prescriber and say, are you sure that that's the dose you want to give? And this would be the dose I would like to recommend. And it's a hard thing to challenge a prescriber. And you have to learn, you know, to have a bit of confidence in yourself and in your own role, that actually this is your job. This is what you're here. This is what you're paid to do.
And it is for safety.
And you might actually, you might actually save someone's life by doing this interaction. So that maybe would be one of the harder ones, especially as a brand new qualified pharmacist. That's always the discussion that you worry about the most.
I think one of the interesting things of when Katie was describing talking to patients, that I noticed there was a lead up. You know, in the interaction didn't just start with the information. There was this lead up, almost like building a rapport first. You know, hi, I know you've been on this medication. Does it work for you? Oh, that's great. I've got some information for you. Or, you know, it's knowing how to lead up to those difficult sort of conversations.
The staff I used to work with, I always used to laugh, because I used to start in a new job, and the first thing I would say to the patients is, hi, my name's Katie. I'm the pharmacist. So anytime you need any help, feel free to come and see me. That's what I'm here for. And that would be my opening in any conversation. Any of the examples I've given you today. Hi, I'm Katie. And it got to a point where the patients would come to the counter. There's 10 members of staff working there, and they'd all go, can I speak to Katie? But, you know, that's building a rapport, and that's what you need. And if I need to have a difficult conversation with a patient about, you know, actually, you have been diagnosed with high blood pressure. You really need to start taking care of your diet more. Or you need to start doing a bit more exercise. I need to feel like I have that relationship with that patient to be able to discuss that. So, you know, it's really important.
That introduction is always so important I think for any healthcare professional.
Great. All right, so we've got a question in the Q&A from Russ. So what are the typical scenarios for OET pharmacy? I'm not sure if this is better for Katie or Virginia.
For which pharmacy?
OET Pharmacy.
Oh, OET Pharmacy. So ask the question again.
What are the typical scenarios in OET Pharmacy?
Well, typically you'll have someone who is coming back, having been prescribed something, and they have had problems, perhaps with they've had side effects, and they come back and say, oh, I'm not taking it, it's no good. So the pharmacy has to gather information about what happened, what was it prescribed for, and then work through possibilities that it might mean that they might need a dose reduction or maybe change to another medication. So that's one of them. The other one is my friend was given this. She's got the same disease as I've got. She was given this. I want that. Why am I given such and such? So the difference between generic and brand names, it's a classic. But it's often it will be a coming back after, perhaps after using a medication or not wanting to use a medication or that sort of thing. So there'll have to be some information gathering about what has happened. Why were they taking it? Not perhaps a first time, although that is possible. You know, I've been prescribed this, and I'm not really sure I want to take it. So as long as there's enough information gathering, and also, you know, it has to be plausible. So it's not going to be for some weird and wonderful disease, or perhaps something that, like a very new medication, because there's a lot of new medications that people will be aware of, but it's got to be an entry level. It's got to be something that an entry level pharmacist would deal with, not something very specialist, not a specialist sort of thing.
It's interesting to hear, and it sounds like it reflects very much exactly what Katie's been telling us that she does in her real life job as a pharmacist.
Again, remember, for all of the OET role plays, there's got to be an opportunity to ask questions, to ask for information, to provide information, and there's got to be some sort of tension point where the patient's worried about the treatment, or not wanting to continue because of side effects, for example, or, you know, there's got to be some reason why that person has come to the pharmacist.
So if there's a contentious issue of some sort, you need to make sure you can show that empathy through your language.
Yeah. And again, you're not being critical of the prescriber. You know, they're, as Katie said, with the hypertension, you know, there will have been a good reason why they've been prescribed a certain medication. So the discussion there. Yeah.
All right, and I think we've got time for one more question. So we've got a question about medical terms. So Katie, you've spoken quite a lot about the patient-friendly language and building a rapport. So the question is, what are the basic medical terms that are required in a medical setting? But I think that's more about what level of medical, let's say, what level of medical language do you use as a pharmacist, perhaps talking to patients?
So I suppose I was talking about sort of setting it to a 10-year-old's level was how I always explained it. A 10-year-old isn't going to know what hypertension is, or, you know, a heart failure, or I'll always describe things to explain to the patient exactly what it is that they're suffering with. You know, high blood pressure, I'm not saying everybody knows what high blood pressure is. I might say high blood pressure and the patient might say, what does that mean? You know, you need to make sure that you match your language to the patient's sort of level of health literacy, which can be difficult when you don't know the patient. I mean, with regards to the question, I can't, it's so wide, I don't really know where to start with.
Actually, something that I'm thinking, and obviously dose is the thing that a pharmacist is going to be so careful with, you know, the difference between a microgram and a milligram, and what's a mil, you know, explaining to a patient that this is how much it is, you know, or and what it equates to with a tablet. Or a you know, liquid that they're using. You know, this is how much you're going to be using.
That's a good point, Virginia, because what we do in pharmacy now is, if you're giving a dose to somebody, you'll always tell them in mils how much to take.
Right.
So you would never say take 500 milligrams of paracetamol.
Right.
You would always tell them the equivalent.
Exactly.
In mils. And then you'll show them, this is how to measure that out on the syringe.
Yes.
This is the spoon you would use to measure
Yeah,
that.
exactly.
So you're not giving them that opportunity to make a mistake.
Yeah, yeah. Especially with those liquid ones, because, you know, they are like so many milligrams in a mil.
Yeah.
And that can be, you know, 5 milligrams in 1 mil. It's easily confused to, oh, is that 5 mils? You know,
Oromorph,
yeah.
10 milligrams of morphine and 5 mils of the liquid.
Yes.
So if I say to a patient, take 10 milligrams,
yes,
they might accidentally take 10 mils.
Exactly.
Which 20 milligrams. So
yeah.
This is where you need to make sure you're very clear.
Yeah.
With that,
And then,
is,
as you mentioned before, you'd be checking, you'd be clarifying, getting them to, okay, so now you show me what it is. Yeah, yeah, yeah.
All right. Thank you so much. Those are all of our questions for today, and that's our time. Thank you so much to both of you for the conversation. It was really interesting, eye-opening, and we've got some interesting comments. And as Rosa said, fascinating, and always really nice to hear that what we're teaching in our classroom is what's happening and helpful for our students. So thank you so much. Thank you everybody for attending, and we look forward to seeing you in our next month's ELFI webinar. So that will be at the end of March. So check out the website for our topic for next month. All right. Thanks very much.
Thanks very much, Ros. Bye.
Bye.